Just easier to stream. I've done that both ways. Sorry about that, everyone. Just easier to stream. I've done that both ways. So, welcome, everyone. Welcome to Medical Mondays with Dr. O. I'm Dr. Toyin Okwesami, a family practitioner, HIV specialist, and I treat addictions in Baltimore, Maryland. Medical Mondays with Dr. O is a platform where we come together and just learn. We learn from each other, we learn from specialists, and it's an open forum where we increase knowledge. Tonight, we have with us one of our best nephrologists out of New Jersey, New York area, well, New Jersey really, going to share with us all we need to know about how we are doing with our kidneys and what we need to know to prevent disaster when it comes to kidney disease. We have the honor of having our own brother, Dr. Segun Simon, who went to medical school at the University of Jos and did his residency at Mount Sinai School of Medicine at Queen Hospital Center, Jamaica, Queens, New York. He did fellowship training at Beth Israel Medical Center in Newark, and currently is the founder and CEO of Kidney Care PA, Maplewood, New Jersey, and also medical director at Next Stage Kidney Care in New Jersey, as well as medical director at Davita Ivington Dialysis. So without much ado, I'm going to yield the platform to Dr. Simon. And I'll also like to let you know that Dr. Nelson Aluya will be co-hosting with me tonight, as well as being a co-presenter for the program tonight. So, Dr. Simon, the floor is yours. Welcome.
Thank you very much, Dr. O, for this invitation. First, I just want to take time to recognize the good job that you're doing in the community. I've heard about you now for quite a while, and it's a pleasure to finally see you in person, although virtually. But I've heard nothing but great things, and I thank you for giving me this opportunity to share with our people what I will refer to as a challenging trend. Kidney issues here in the diaspora and back at home has been ravaging us like nothing we've seen before. So I will speak very briefly, maybe about 15 minutes. I have a few slides I will just go through quickly to give us sort of an overview of the kidneys. First, what are they? Then what do they do for us? And how do we recognize if there's something going wrong with our kidneys? How do we get tested and diagnosis? What are the things we can do, to help keep our kidneys healthy? And when we do get kidney disease, how do we go about managing them? What are the options we have? So I titled this, How Are Your Kidneys Doing? This is because this is what I mostly ask my patients when they walk into my office. And you can always imagine the answer I get, which is always, oh, my kidneys are fine. And then I tell them, well, but you're walking into a kidney doctor's office. So if you're walking in here, I can guarantee that your kidneys are not fine. So, and then that's how our consultation typically starts. So what are the kidneys? They are bean-like organ. I don't know if you can see this picture that's present, I would say, in the upper part of our belly area. And they are closer to the back than the front. If you look at this picture very well, you see the heart up there, the big red sign, and a little lower down, just above the pelvic bone, you see two bean-like shaped things, and those are the kidneys. Next slide, please. Now, this is a closer picture. We're now in the belly, and you can see. And if you look very closely, the one on your left, you will see a little bit of a finger-like things. Those are the projections inside the kidney. That's exactly how the kidney looks like when you zoom in or you look at it under the microscope. Sorry, let me just make sure my camera, okay, good. And they are, those finger-like things are filters, and primarily, we'll learn about them later, that they help us do the work that the kidney does. And how do you locate your kidney? If you stand just like this guy in this picture with your back, your hands resting on your waist, you're most likely resting your hand on top of your kidney. And like I said, they are located primarily much closer to the back. So they are reachable very quickly through the back. If you have pain, for instance, in those areas where this man is holding, it could be from your kidney. Not all pain from there necessarily are from the kidneys. For the purpose of everyone, and I've tried to make this very, very simplified. So I know not everyone here is a doctor, so we can all just follow along. And please, if you have questions, the moderator will let me know, so I'll allow people to ask questions in between. Now that we know what the kidneys look like, what do they do for us? So the kidneys are part of what we call the urinary tract system. And in this picture, you could see the bean-like shaped organs, two of them on the top. And when they filter the blood, they form what we call urine. And the urine flows down through that little tube called the ureter. And the urine goes down to the bladder, which is at the base of the pelvis. And once the bladder is full and we feel the urge to urinate, and then we go to ease ourselves, and the urine flows out through what we call the urethra. So all these three things combined, we call them the urinary tract system. Next slide, please. So now, what do the kidneys do for us? They filter the blood. Filtering the blood for what? We know what filters are. If you remember, like sieves, our grandmothers and mothers back in the village, when they get their rice or beans, they put it in a little basket and then they sieve it. And then the dirt and stuff we pass through, and the beans will stay in the basket. That's sort of what the kidney does. When the blood flows through it, it filters it, and all the bad stuff, the toxins, from everything we've eaten that day, from everything we drank, from all the medications we took, those toxins goes into the urine and eventually gets eliminated. So you realize that the kidneys play a pivotal role in keeping us healthy. So it excretes waste, which could be from food, from drinks, from drugs. It also keeps us in good volume status. What do I mean by that? We're not swollen, though we drink water every day, but we're not swollen. That's because the kidney helps us to excrete or urinate out the amount of water we drink, so we stay dry and nice. It also has some endocrine function. It's okay, you can go to the next slide. And endocrine, what I mean by that is hormones. The kidneys produce some hormones that help in maintaining good health. One of them is vitamin D. And vitamin D helps us to absorb calcium, and this is really good for bone health. It produces other hormones that helps us to make blood cells. And so you'll find that some people may have anemia, which is low blood count, primarily because they have kidney disease and they are not able to make those hormones. So those are some of the functions of the kidney. It helps us to regulate blood pressure. The kidney actually does a whole lot more than the heart, for instance, when it comes to blood pressure regulation. So if we have kidney disease, we might have trouble controlling blood pressure. Next slide, please. Now that we know what they look like, we know what they do, sort of. What about when they get diseased? There are two basic categories when it comes to kidney disease. There's the one we call the acute, meaning it happens somewhat rapidly, generally within days to weeks, and typically less than 3 months. This type of kidney damage are often potentially reversible because the damage typically occurs as a result of something else going on. For instance, we could have, let's say, serious infection like pneumonia, and while the infection is going on, the kidney can shut down temporarily, either halfway, quarter away, or even a whole. And then as we treat the infection with antibiotics, eventually the kidney recovers. So those are called the acute kind of kidney injury. Now, the other type is the chronic one, which goes on consistently for months, years, and those types are typically not reversible, especially if they are not caught on time, and it could go on for years without us knowing. That's because kidney damage goes on without people knowing what they are until the kidneys are really, really, really far gone. And those are the ones we typically should pay attention to. And a lot of the talk today will be focused on that because those are the ones that cause a lot of trouble. Before we get them, sometimes it's too late. Now we're talking dialysis and stuff like that. So that's the chronic type. Now, what are the causes of the acute ones? I've enumerated a few ones here. Infection being the major part, severe dehydration. If you go on for hours and days, for instance, fasting without drinking, without eating, your kidney function can be low because of that. But again, those are typically reversible. Once you hydrate, then the kidney is happy again. There are certain medications that can shut down the kidney. Drugs like the ones we call non-steroidal anti-inflammatory drugs. Examples are like Motrin, Aleve, Advil, naproxen. So I see people, pop on those pills for headaches, for joint pains, for arthritis, for all kinds of things. And oftentimes it can cause a lot of damage. Also, other drugs like antibiotics, there are, several drugs that can cause, even if they are prescribed by doctors for certain things, they can cause a reaction in your kidney. So we always tell people it's important that you have your blood checked every now and then with your doctor to make sure all the organs inside are responding well to whatever medications you may be on. Excessive smoking, obesity, older age, those are some of the other risk factors for acute kidney injury. Now, for the chronic ones, yes, please stay here for a few seconds. For the chronic disease, kidney disease, diabetes and high blood pressure are two of the leading causes of this worldwide, whether in developing world and developed countries. If you have both, then you can just imagine the double whammy effect on your kidneys. So if you have diabetes or you have high blood pressure, you definitely should have your kidneys checked regularly. Now, other things will include family history and some genetic diseases. I would love to dwell here for maybe a few more seconds because of the people in this chat today. I believe we're primarily mostly African Americans or Black or Africans. And there are certain diseases that are peculiar to us that increases our risk factor to kidney damage. Now, the diabetes and the high blood pressure that I mentioned are risk factor for everyone. But when it comes to Black people, this risk appears much increased. And recently, there are some genes that have been identified that may be implicated into why this is increased. And one of these new genes is called the APOL1 gene. It stands for apolipoprotein 1. Now, this gene is present in everyone. However, among the Black population, there's a variant of this gene that has been identified. They're called the G1 and the G2 variant. And people that have this variant have about 10 to 20-fold increased risk of kidney damage. And this damage occurs at much younger age than we see in other ethnicity. So a lot of work is being done to really evaluate more how this gene is being transferred from parents to offspring. It's sort of similar to the sickle cell gene abnormality that we believe occurred during evolution as a form of maybe some protection against malaria. This APOL1, apolipoprotein 1, that's supposed to help us transport cholesterol in the body. Once we have this variant, for some reason, it makes our diabetes much more aggressive towards our kidney. It makes our blood pressure much more aggressive. And people with HIV, which I believe Dr. O is a specialist in, a Black person with HIV has an increased risk of kidney disease than a Caucasian with HIV, especially if they have this gene. And the prevalence of this gene is about 13% in the Black population in this country. And so that tells you that, translates to about 4.5 million Blacks at increased risk of this. And if you walked into any dialysis unit in this country, in whatever state, no matter the demographic in that state, I can guarantee you will still see more Black people getting dialysis than white. And I think this gene has a primary role in it. So I delve into this a little bit more just to let us know that we are more at risk of kidney damage than other ethnicities. So we need to take this seriously. Sickle cell as well by itself is also a risk factor. And now we go to the stages of kidney disease. There are 5 of them, stage 1 through 5. 5 being the end stage. That's when typically people need dialysis. You could go from stage 1 through 3, 4 for a number of years. It could take you 20 years even or more before you get to stage 5. Now, the reason I'm saying this, and you typically won't feel anything as you go through stages 1, 2, 3, 4. So again, you don't need to wait until you have symptoms, until you feel something before getting your kidneys checked. And these stages are based on what we call the GFR, which is the glomerular filtration rate for those who are interested in what that stands for. And it roughly translates to the percentage of your kidney function. So I always tell my patient, each time you see your doctor and they do your blood test and you go for the results, don't just accept, hey, Mr. A, your results are fine. I'll see you in 3 months. No. When it comes to the kidney, I tell every one of my patients what I call their kidney number. You can ask, doc, what exactly is my kidney number? Am I at 30%? Am I at 45%? Am I 90 or 100? So that way, when you hear the number, I think it makes you pay more attention. For instance, if your doctor says, hey, your kidneys are functioning at 18%. And that will ring a bell. You may be like, wow, I feel great. Yes, you do. But guess what? You're 3-4 points away from not feeling great. And the thing is, by that time, if you wait till you're not feeling great, it's often too late. And then we start talking about just kidney replacement therapy, which on its own is another topic and is not very easy to deal with. Next slide, please. Now, how do we recognize when you have kidney damage? Again, like I just mentioned, it could take years before you know it, especially with the chronic disease. With the acute one, typically you feel that quite early, but again, it's because you're sick from other things, and even the symptoms from the infection, for instance, causing the kidney damage can overwhelm the signs of the kidney. But by and large, these are some of the things to look out for. If you're excessively tired, and you're just drowsy and feel sleepy all the time. I know this sounds so simple. Sounds like, oh, everybody feels like this every now and then. But yes, if it goes on and not getting better, don't say, oh, I just have the flu and this flu is not going away. Some people say, oh, I'm just getting old. And so I say, just get to your doctor, have your kidneys checked, and let them tell you what your numbers are. If you see blood in your urine, that's an obvious abnormality. Nobody should have that. You should have your kidneys checked. If when you pee, the bath is like a bubble, like it's like there's a soap in the toilet, that is a red flag. It could be a sign of too much protein in your urine, and that is abnormal. You should have your kidneys checked. If you have baggy eyes, swollen leg, or you can't breathe after walking a few distance, or you have chest pain, this could be signs of fluid accumulating in your body because the kidney is not able to get rid of them as it should. Remember, I told you some of the functions of the kidney was to help us, eliminate water so we are not swollen. So if you are swollen, it could be a sign of kidney disease. It could be a sign of heart failure also, but the kidney should definitely be checked. If you're nauseous, vomiting, you're not able to take anything orally, and it's going on for days and weeks, this is a big red flag. And the reason for this is because the body is not able to metabolize whatever food you're trying to put in. So the body rejects anything coming in because the kidneys are sick and not able to excrete the waste from it. And that's why the people with kidney disease get really nauseous. They start losing weight, and a big sign that we should check our kidney function. Next slide, please. So how do we keep our kidneys healthy? 7 golden rule: eat a healthy diet, be active, control your blood pressure, don't smoke, plenty of fluid, manage your weight, and get your kidneys checked regularly. For people that are healthy and young, no issues. I say at least once a year, visit your doctor, have them do a whole panel on you to see what your organs look like. And for people who have diabetes, high blood pressure, and other chronic conditions, I would say at least every 3-4 months, especially if you're taking several medications, you want to always check to make sure that none of those medications are overwhelming your kidneys, because they can, or that none of them is causing any reaction to your kidneys, your liver, and other organs. Next slide, please. People often ask me, oh, what can we eat or drink naturally to keep our kidneys healthy? The truth of the matter is, whatever we do as individuals, to control our diabetes and our high blood pressure, plenty of fruit, vegetable, be active, that always works for the kidney. The kidney is always happy in that environment. There have been a lot of questions asked of me about our own food in Africa, what we can eat to help with the kidneys. I do not have a lot of landmark studies on those, but generally I say fruit, vegetable, keep your weight down, maintain an active lifestyle, and stay hydrated. Next slide, please. Okay, yeah, this is a video. It's not going to, it probably may not play, so don't worry about it. So that's the end of the kidney talk, overview of kidney function and signs and symptoms. So I don't want to go too long so we can leave room for a lot of questions. I believe during the Q&A, we will be able to cover specific topics and other areas that we're not able to touch on. Thank you so much. Thank you, Dr. O.
Thank you so very much. That was incredibly educative. Thank you. I appreciate you. Oh my gosh. I have a question for you. This is a myth that I want you to maybe help us dispel. You know, I see patients all the time and they come in, they say, oh, they have back pain. So they have problems with their kidneys. They convince me that it's, or they try to convince me that their back pain is due to kidney problem. I saw everything you listed. I didn't see back pain there. Yes, the kidneys are located towards the back, but when you have back pain, is the kidney problem? Kindly comment on that.
Yes, this is an interesting question. Funny enough, I showed that guy holding his back with what seems to be like a sign of pain. The kidney most of the time do not hurt. Despite its very good nerve supply, it's covered with a capsule that somehow pain is not one of the earlier signs or even late signs of kidney damage. Now, having said that, there are one or two conditions about the kidney where pain, especially in the lower back or the flank area, could be a presenting sign. Now, if you have kidney stone, so if you have stone located within your kidney or within that little tube I showed you where the urine flows through, and so it blocks the passage of urine, yes, pain could be a cardinal sign. So if you have kidney stone, if you have kidney tumor or cancer, and the cancer is getting so big that it's stretching this capsule that covers the kidney, yes, you can have pain. If you have a really, really bad urinary tract infection that has ascended from the urethra to the bladder all the way up to the kidneys, it's rare, but we see this, and especially more so in female as well, you can have pain. Outside of all those three conditions, most of the time, causes of the kidney ongoing damage for years and years, you typically don't get any pain around the kidney.
Thank you. Thank you so much. That was an important question. I think that we all need to pay, answer that we need to pay attention to, because, when you really have kidney problem, like you discussed, it's not the back pain. So before I call on Dr. Aluya, because I'm going to call on him in a minute, there's a question here that a family member has a strong smelling urine. Is this an indication of kidney disease?
Okay, so strong smelly urine, very subjective, but could mean so many things. And I'll approach this way. For instance, if you're very dehydrated and your urine is a little bit more concentrated, and once you're dehydrated, the body is trying to conserve fluid. So it doesn't let out much urine. It maximally concentrates this urine. So the urine is full of more toxins. You could perceive the normal smell of urine higher. Now, this is normal. Once you hydrate and the body is happy to let out more urine, that smell goes away. Now, there are also certain food that can make your urine smell. There's this vegetable, the name is, it's green, it's like pencil. I don't know, whoever can remind me.
Is it asparagus?
Asparagus. Yes. If you eat asparagus, literally, I'm talking about 6-8 hours later, you go to pee, you can perceive some type of smell because once it's metabolized, there's a chemical that is excreted from that. There's certain drugs that can change the color, the smell of your urine. So not every smell of the urine is dangerous. Let me put it that way. It could just be a reflection of how hydrated you are, or some other things that you've eaten or drank the days prior. Having said this, if you're not sure what this smell is all about, it could also be an infection. If you have a urinary tract infection, your urine will smell awful. If you're not sure, and this is abnormal for you or new to you especially, you should have it checked. It costs $7. So even for people who have no insurance, and I'm sure you can buy yourself a cup of coffee a day, it takes $7 to get a comprehensive blood kidney test, including the urine. So it's really not that expensive to check your urine. Thank you.
Thank you. And that's with like LabCorp, Quest?
With LabCorp, Quest, they typically tend to have, if you don't have insurance, that is,
Yeah.
they typically tend to have deals for people who are uninsured because you're paying out of pocket. And in this area, it ranges between $7 to $10 for a comprehensive metabolic panel. Urinalysis is even much cheaper. And with those two, you could essentially have checked the whole, what your kidney is doing.
Yeah. And if you go online actually, and you go to their site, people can actually order these tests themselves. You know, it's incredible. You don't need a doctor to do it. I found out, or wait a minute, you need a doctor to let you know what to order, but there's a way to put it in and then you pay for it. Yeah. So, Auntie Tower, you have your hand raised. Kindly unmute, ma. Auntie Tower is from Florida. And, by the way, I want to acknowledge all of those from Nigeria. I just saw one of my uncles texted me asking if, everything is now okay because of the, frazzles we had in the beginning. And he tuned in from Nigeria. Brother Sonjo, thank you for attending. And everyone from the UK, from Nigeria, all over the world, welcome, and all over the US. Auntie Tower, go ahead, ma'am.
Talk about
good evening, everyone.
Good evening, ma'am.
I'd like to ask some question. The main one is about the dialysis and kidney transplant. The dialysis, once one gets into dialysis stage, is it reversible or is it going to be lifetime stuff? And how long can you be on dialysis before you pass away if you don't get a transplant? And with the transplant, what is the lifespan when you get a transplant?
Thank you so much. These are really, really important questions. I left them out for a reason during the presentation because I know they are big topics once I start talking about them. Now, the first one is dialysis. So dialysis is a form of kidney replacement therapy. So we've determined that your kidneys are gone and not coming back in the case of chronic damage. And so now you need something else to do the work of the kidneys. And dialysis is generally one of them. The other one, kidney replacement therapy, is the one you mentioned, kidney transplant. This is better than dialysis because it gives you a chance to live as close to normal as possible. Now with dialysis, can you come back once you start dialysis? If it is a chronic damage to your kidney that has occurred for years, the answer is typically no. How long can you live on dialysis? It depends. It depends on the age you started. It depends on how well you follow with your doctors and you follow all the recommendations they give you. They will say don't drink too much, don't eat certain foods. and things like that. Then some medications you have to take. The reason is because now that your kidneys are gone and you are relying on this machine that you go to sit with for about 3-4 hours. Typically here we do about 3 times a week. And I say here because I'm talking about in the United States, for those who are not here listening. And those 3-4 hours, the machine tries to clean your blood and filter all the toxins that you've eaten over the last 2 days or so. So the more toxins you generate or you put in your body, the more the machine has to do on you to clean you up. And so if you're able to limit your fluid and all the bad stuff the doctors, the dietitians say don't eat, then you can live relatively longer. There is no specific number of years. I've had people on dialysis for 25, 30 years, for more than that. But I've had people who didn't make it past, 3, 4. It just depends on so many factors. So we typically tend to individualize people at the time they get on dialysis. If you're 47 starting dialysis is different from if you're 82 starting dialysis. So it's sort of like that. But it typically does not come back.
Your urine gently and go out.
For the
Sorry about
transplant,
that.
yes. For transplant can last as long as you care for it. There are 2 kinds of transplant. That's how I will explain
I'm
this.
told if you go and wear your pajamas, if I come out and like this, you are new.
Okay. So there's a transplant from a living donor, and there's a transplant from a deceased donor. Now, God has been so kind to us. He blessed us with 2 kidneys, every single one of us. The truth of the matter is we can live on 1 kidney for many years and healthy. So if you're able to get a transplant from a living donor, someone who is alive and has this, and we found him to be really healthy, has no underlying disease, or like he's not a high risk for kidney damage later, and we clear them to be able to give up one of their kidneys. If you get such a kidney and you take care of it, it can last you almost close to what your normal lifespan should be. Now, if your kidney comes from a deceased donor, meaning someone who has passed away, typically we'll say maybe a young person who had a car accident, and did not survive the accident, but they've indicated maybe on their ID card or in their will that should they pass, they would like to donate their organs to people who need it. Or sometimes we approach their families because we see these people, young 21-year-old riding a bike, and crashes and, not able to survive it, but the organs are good. And we have people on the list waiting for organs. We approach the family, and if they agree, such kidneys are very, very helpful. They can still last for years, but they are typically not as good as the living donated one, for the reason being that, while the patient is dying, blood pressure has been low, there's been no perfusion to the kidney. So the kidney may have suffered some damage already before it's harvested from the dying patient. And then it stays outside also for a few hours, but it has to be flown from one state to another, from one city to another, to the person who is eventually going to get it. So throughout all this transportation process, they try to keep it alive and make it seem like it's still in the body, but it's not, as natural. But by the time it gets there, there may be some minimal damage already. They are still good, still better than dialysis, definitely, but they may not last as long. So overall, the overview is that a deceased donor can last you up to 10 to 12 years, 10 to 15. And a living donor kidney can last you up to 20 to 25 years if they are well taken care of and everything goes well. I hope this answers your questions.
Thank you very much. It does.
Thank you so much for that wealth of information. Dr. Aluya, If I may call on you, are you there?
Hello, good evening, everybody.
Fantastic. Good evening. Welcome.
Yes, thank you, thank you. Good evening, everybody. It's good to have everybody here. I see so many people on. This is
Please properly introduce yourself. I'm sorry.
well, I'm Nelson Aluya. I'm medicine and pediatrics trained. Currently the chief medical officer of the Newark Community Health Centers, which is a group of 7 health centers, which is a federal health qualified center here in the state of New Jersey. I call myself a medical advocate. So I advocate on medical issues that concerns our people, because we need people who speak for us on that platform. Like they always say, if you're not at the table, you're at the menu. And for so long, we as the people have always been on the menu on so many fronts. So one of the other things in other life that I do is on a little bit on the political front. I'm the president of NAPAC, which is the Nigerian American Public Affairs Committee, USA. So we help identify, raise, mentor, educate our community on policies and politics, as well as encourage Nigerians and those who are friends of Nigeria to get involved in the political space so that they can also be office holders in politics. But not just that, not everybody is interested in politics, but then your child can work for somebody who is a Nigerian-born politician who is in office, and they will be the policy advisor in that space as well, so that our words and our interests will be protected. For so many reasons coming up, and I must thank Dr. Segun Simon, who's a very good friend of mine. I've known him for decades now, who has done a fantastic job on educating us on issues in the kidney. I must tell you, kidney disease is one of the most frightening disease that's out there, because anything you eat, drink, or take in, or even breathe, will pass through organs that have to break through them. One is the liver, and the other one is the kidney. As soon as it goes through the liver and is broken down, whatever remains has to pass through the kidney. You have to excrete it. Water, medications, food, everything else. So it's so important. And I often joke and I say that the kidney is such a what do you call it? High profile, high maintenance organ. It's very weak. If you get dehydrated, you see it folding up. If you do anything, it reacts so quickly. Especially, it gives you early warning signs when you do blood work. You see there completely. And for a few, just like Dr. Segun Simon has said, if you look at your urine, every time you pee, look at your urine and see what color is it and what's the smell. Are you having any burning sensation? Are you having any discharge? All of those things do matter. Some people pass on stones with knowing it or without knowing it. From what you were saying, back pain, on the side, it's called a flank, really. The pain goes down to the groin and towards the urethral area when you pee. That kind of pain is a pain that's significant for kidney stone. Some people have a propensity for kidney stones. It runs some families, especially for those who eat, with the propensity, but eat a whole lot of lettuce, cabbage foods. We've had those because they produce different kind of stones, oxalic stones and all that. So all of this with, when Dr. O and I, so wholeheartedly asked our very eminent Dr. Segun Simon to come talk to our community, because we see how important it is. We've had a lot of story, and unfortunately, and let me give you the statistics, because again, data is so important so that we know where we stand. I always say this: no data, no problem. No problem, no funding. No funding, no solution. What it means is, if you don't have the data, you don't know if you have what problem that you have. And if you don't have the data and you don't know there's a problem, you can't look for the money to fix that problem. And that's just the way it is. And for so long, our community have been suffering and suffering from all of this. And that's why it's important that we come here. I see 100 people here, which is great. We come here so that we'll listen, and not just listen, but share the news to our fellow brothers and sisters. There's an African adage that says, if you hear good news, you listen with both ears. So I hope you're all listening with both ears so that you can share that information out to our community. Now, the data says, globally, around the world, about 10 to 13% of our 8 billion people, thereabouts, have chronic kidney disease. And that's a huge number. So if you put it down in that number, it's about 700 to about 1 billion people around the world with chronic kidney disease. I'm sure that's even a little more. Now, if you draw it down to us here in the US, about 37 million people is said to be living with chronic kidney disease, and with about 200 and something thousand of them on dialysis. Again, and that's a totally different story.
Hey, close that water. What is you watching?
Dialysis is a disease.
What are you watching?
And that's why when I tell people about taking care of themselves, I say, look, God forbid you end up on dialysis. That's a disease. You know, some people are like, oh, take your blood pressure medicine. I don't want to take it. You take it today, you forget. Blood pressure is good. You forget. Look, if the kidney fails and you get on dialysis, you're going to add more medication in itself on that. Now, still coming back to that, to the issue of chronic kidneys in our community. In the US, it is said, I mean, the incidence is about 15% of the population live with chronic kidney disease. And that's about 1 in 7 people live with chronic kidney disease. But guess what? 9 out of 10 people don't know they have chronic kidney disease. And that's why when Dr. Simon said, please, every time you go for your doctor's visit, have them check for your urine. Look, I'll tell you this, everybody here who can hear, you ought to have your own personal doctor, period. You have to have your personal doctor. And the minimum exam you get is 1 annual check every year. You have to, because I was telling somebody the other day, I said, you drive your car, right? He said, yes. I said, okay. Now, do you take your car for service? He's like, yeah, I take my car for service. I said, okay, if you take your car for service, how much your whole body, who is doing the job every day, you're not taking it for service. And that's what we need to know. Because if that car stops, everything stops, including your finances and all that. But even guess what? If you stop, everything stops. We know what COVID did to the world. The COVID really showed us to the world that, listen, once health is the #1 most paramount thing on earth. If health stops, everything, the whole world stops because of a tiny virus that we could not even see. So that's why it's so important, because like I said, 9 out of 10 people don't even know they have kidney problems, even in this country. In this country, the most advanced, technologically advanced country in the world, with all the Medicare, and all those things that they have, they still don't. And bringing that to our color, we as a people constitute about, some people say 13 to 15% of the population in this country. But guess what? 34% of us are on dialysis. Why? 34% of us are on dialysis. That's a huge number, but there are reasons for it. And one of the things that I thought about was, because it got me worried, why are a high number of us on dialysis? And Dr. Segun Simon, alluded to it, because 1, high blood pressure is higher more in us. 2, the incidence of diabetes is about 12 to 15% in our community, which is huge. Now, if you add diabetes and obesity and the food that we eat, it's a big, big issue. And forget the other, chronic inflammatory states that we now realize that we're constantly on as Black people because of the food, the purified sugar that we eat. And not just that, but because of, let me use that, the things that make us resilient, meaning the inheritance of our struggle, keep us on a chronic inflammatory state. And I've done, when I check, inflammatory markers for our people, I see that on the average, our people have constantly have high inflammation going on. And that, again, is adding to the risk of us being on dialysis and everything else that we do have. Now, guess what? The number one cause of kidney failure in the world is high blood pressure. The number one cause of kidney failure in the world is diabetes. Number two is high blood pressure. If you have those two, again, like Segun said, it's a double whammy. It's a big problem. But one of the things that he mentioned, and that's why advocacy is really important, where I hope we'll have out of this day today, we'll have people who are champions, who have network in our community, who can speak to those in Congress, speak to those in government. Because if you have a familial, or genetic familial issues, when he talked about the APOL1 gene defect, that is something that is new that they are working on. Again, we're seeing that in our community, about 15% of us do carry that gene. It's a big issue. Now they begin to wonder, why do we have that gene as compared to the rest of the population? If you carry that genetic component or the defect, in fact, like he said, the G1, G2, and G3, like some people talked about, if you carry the inheritance, the recessive inheritance, it's such a complex thing, but not to go into that. It's inherited in the same form as sickle cell is inherited. Now, if you have one of those gene defects from your mom and you inherit it from your dad, that means it becomes two. The chance of you having that defect, just like you heard from sickle cell, a lot of us are very aware of what sickle cell is. The same manner, if you carry those two genes, the rate at which your kidney deteriorates is about 20 times faster than those who do not have diabetes or even high blood pressure. Now, if you add high blood pressure and diabetes on top of it, it becomes a big issue. Now, you begin to wonder, why do we have that defect? Again, the same way that our body tried to compensate for malaria, the trypanosomiasis that we have back home, especially in the West African region, also give us that risk, that to protect us from having trypanosomiasis, which is the African sleeping sickness. A lot of us know that. That's when the genetic modification took place. It takes it in two forms. There's polymerization and then some deletion in some proteins that come up. So if you carry both, you have a higher risk of the kidney failing. Now I'll give you a typical example. For those who are Nigerians who heard the story that happened, I think early this year, our former Senate President, Ekweremadu, you all know what happened to him. He's in jail right now with his wife and the doctor who tried to harvest a kidney in the UK, because they brought a young man to the UK and went to harvest under some funny stages. Now, when the daughter, because what triggered me, I was wondering, why is a young girl like that, who lives in the UK, whose family are wealthy, at least they have means, need a kidney? Why did her kidney fail? But when I listened to her interview, she said it. She said, I have kidney problem because I inherited from my mom and my dad the defect called APOL1 gene. She said it, but a lot of people did not pay attention. So you can imagine what that genetic defect can occur and how it has translated to real life situation that's affected and destroyed the family. Because in all sincerity, Ekweremadu and his wife, what they were trying to do was just help their daughter, period. No matter how much or however they did it. But you see, these things are real. They are real life incidences that happen. Now, that's the one we see and hear in the news. What else is happening out there? How many of our children, brothers and sisters, whose kidney failed that we had no idea back home, especially back home? And then in this country, unfortunately, they've not been screening for that. So the advocacy component is this. Maybe it's time that some of you will join me and Dr. Simon so that we can advocate that just like they screen kidneys, sickle cell in our babies, we need to begin to screen all our newborn for this gene, so that if you know that your child or you carry that gene, or your child carries that, you want them, if they're marrying somebody else, just like you want your child to check for sickle cell in his or her spouse. As time, this is the kind of discussion we must begin to have as well. Because the reason why we're able to screen as a newborn for sickle cell, because people advocated for it. They didn't care before. When our young children were dying for sickle cell, nobody cared because it's not their disease. But when one of us started advocating and we pushed them together, that's why we screen. So it's about time we also begin to talk so that we begin to screen for that. Because you know why? That rate of deterioration of kidney actually starts in a young age. It doesn't start when you're old. It starts when you're younger. And that's why we must begin to pay attention. So I will stop here. I'm sure there are a whole lot of questions that people have. I will be there to help answer those questions. Thank you and God bless.
Thank you so much for shedding more light, for, expanding what we, already learned some of tonight. So appreciative. Alan Ngore had his or her hand raised before. Kindly unmute. I saw that hand raised before.
Yeah, what I wanted to ask has been answered, so no need for it again.
Fantastic. Thank you. See how thorough our experts are?
Yeah, very thorough.
Thank you. Appreciate your participation. And I want to appreciate everyone on the platform. We have 100 people on the platform, and so people are not able to get on. I'm receiving texts, that they can't get on. We'll see how we will make this unlimited. So thank you so much. We're glad you were able to make it in tonight. That's why it's good to come in early also. Thank you. Auntie Ngore, I think you're the one raising your hand. Kindly unmute.
Yes, ma'am.
Yes, ma'am. Welcome, ma'am.
Good evening, ma'am. How are you doing?
Fine, thank you.
I need to ask the question, what is the benefit of cranberry and cranberry juice or cranberry or lime to the kidney?
Dr.
I'll take that.
Simon?
Yes. Yes, this is a popular question. Almost every platform I go and I talk about the kidneys, someone asks about this question. There is a benefit with cranberry juice when it comes to the kidney, only in one condition, and that's a urinary tract infection. The science behind it is that when we drink cranberry juice and the kidney filters it, there are some natural bacteria in the urogenital system. They act on some of these chemicals from the cranberry juice, and so they alter the pH of that area, and so it discourages bacterial growth. So this is about the summary without going into what those chemicals are, how the reaction takes place. But yes, it is true that cranberry juice can help to some extent limit or prevent urinary tract infection, especially for females who do get UTIs a lot. Outside of that, there's really no other non-significant benefit for the kidneys. Thank you.
Thank you. What about lime? I think she asked about lime.
Lime, I'm not aware of, but cranberry juice, yes.
Thank you. Dr. Aluya, lime? I'm not aware of lime.
I'm not aware of lime. Okay. Maybe the same, changing the pH, structure in the same area as well. I mean, cranberry juice, if you look into the details, for some reason, some have said some of the chemicals, a little name, not to go into that, tends to form, it lines up the endothelial wall of the urinary tract. So it forms a thin film as a barrier as well as changing the pH. It forms a thin layer of barrier on top of the urinary tract so that when bacteria come, it's hard for them to stick in through to attach themselves. So I've used cranberry juice a lot in a nursing home. For those with repeated UTI, we just put there 1 gram every day, and it tends to help and reduce the risk for
UTI. Urinary tract infection.
Yeah,
Thank you.
urinary tract infection.
So we have, okay, now you've got to introduce yourself because you have iPhone on.
Okay. Is that me, Dr. Popola?
Yes. Dr. Kokwala,
All
nice
right,
having
thank
you.
Yeah, it's
The
your
floor is
boy,
yours.
and Aluya is your boy. Now, what's the connection between sweating and the kidney, and that the skin and the kidney? Because on occasions, we'll say the skin is doing some of the work of the kidney, and doing things to make you break into a lot of sweat may help to reduce the strain and stress of the kidney. Please hear expert opinion, sir. And ma'am.
Dr. Simon?
Thank
Thank you.
you so much. This is an interesting question. And so the skin, as it may, can serve also as an excretory organ. Just like, the GI system, we, what's the good word now? We excrete feces. The urinary system, we urinate toxins. So the skin is a good part of the body that, because the cells there are capable of excreting some waste or some chemicals, and primarily through sweat. But also these cells have the ability to adapt and modify themselves, especially when the body is under stress. So if you analyze sweat, for instance, it's made up of a lot of chloride, sodium and chloride. So if you try to taste someone's sweat or even your own sweat, it's a little bit salty. That's a good way of excreting excessive sodium and chloride from the body, just like the kidney does. So I think that's where people draw these similarities, this parallel. But when the kidney is diseased and is not able to carry out all the excretory role it's supposed to do, the cells of the skin have this ability to adapt or modify themselves to try to get rid of some of these toxins. It's not typically what they do in a normal condition, but again, when your kidney is damaged and the body is just looking for other ways to keep the host alive, the skin can do that. And typically back in the days, or even when we practiced in Nigeria years ago, as medical students and stuff, because of this function of the skin, a kidney disease patient have a typical smell when you approach them. That's because these toxins that they are full of is just trying to get out of the body one way or the other. So one of them is through the skin. Sometimes they breathe it out. And so the room is filled with this, pungent smell that you can almost detect. So yes, in those conditions, you can say the skin is trying to assist the kidney in eliminating waste, urea, uric acid, sodium, chloride, and other things. But in a normal condition, not to a significant degree when your kidneys are able to handle it. Now, if you're exercising and you're sweating, that's a little bit, it's slightly different form of excretion than when we're talking about disease state. You can lose a lot of fluid even through that means. And so we talk about hydration when people are, working out and sweating a lot, because sodium and chloride is the way the body maintains its fluid balance. So I hope this is able to share a little bit of an overview about the skin, being able to excrete stuff. This capacity is enhanced when there is kidney damage or an organ failure, let me put it that way, both the liver and the kidney, actually. I don't know if Dr. Aluya may have some more on this.
Well, I would say this, that your body is truly your temple, and you must take care of it. Because guess what? It's the only place you have to live, right? Your body is the only place you have to live. Outside of that, there's nothing else. Now, you alluded to that earlier on when you talked about the skin and the kidney functioning as a level of for anemia and also for other metabolites, for instance, even vitamins. Big deal, vitamin D, huge, because when we as Black people come out in the sun, I mean, I like to talk about anthropology, as we go on. Listen, I often joke and I say this, that we as Black people were not meant to be living here. I mean, those of us who are living in temperate area, we're not meant to be here. When God created us, put us in Africa. But for some other reason, we found ourselves here. But guess what? Life began in Africa, period. There's no contest about that. Now, those who left Africa, who you see here now, who are Caucasians, left 30, 50,000 years ago. And in the process, were able to undergo some genetic change. The same genetic change we talk about, why our kidneys are having what it is now, why this is happening and all that. They took 50,000 years to get to where they are. We just came only 500 years ago. We're still very brand new. And the Apple A1 gene, when they talk about it, it's actually a new mutation from what they describe. It's actually new for those who are in the West African region. But a connection of the skin and the kidney, they work hand in hand, in as much as it helps excrete, keep water, keep homeostasis, get rid of some salt and uremia and all that. It also helps as a first stage of breaking down vitamin D, that eventually goes down to liver and eventually comes down to the kidney, where the whole process is complete. So all of these things, work together, and that's why we must protect each and every one of them.
Thank you. Thank you. Dr. Izugu, kindly unmute. Dr. Simon, Dr. Izugu is a cardiologist here in Maryland. I know you've not met, so I'm introducing him.
Thank you, Simon and Aluya, for that excellent presentation and discussion. I have a question more to do with what we see from cardiovascular perspective in renal protection medications with ACE inhibitors and ARBs. So what we find many a time is that many of our African brothers and sisters, they are placed on lisinopril. And before you know it, they get allergic reaction. And then their record they carry, they're allergic to ACE inhibitor. And once that is labeled, then they can't get any of our cardioprotective medications, not even medicine to treat heart failure and all those things, because nobody wants to be faced with lawsuits because of allergic reaction. And so we try to do more of use of herbs on our patients and really want to know, from your renal perspective, do you guys discriminate on that based on this being an issue for Black patients in having higher allergic reaction to ACE inhibitors?
Thank you so much, Dr. Izugu.
Yes.
It's always nice to have a cardiologist in the house, because we have this never-ending banter between the heart and the kidney, which is more important to the body. But I won't go into that today. But yes, this is one thing we find that problematic actually in the renal world. Use of ACE and ARB. Now, both of them offer similar cardiorenal protection, meaning protection for the heart and the kidney, so similar extent. But because of this quote-unquote allergy, which seems to be more with the ACE inhibitors, like the lisinopril kind of medications, most nephrologists, including myself, we just start with ARBs for most people, just to bypass labeling a patient that is allergy. Now, even in the cases of allergy to ACE inhibitors, we have to know what kind of allergy it is. Now, if it's just cough, which is very common due to bradykinin accumulation in the pathway, that does not exclude the use of ARBs in those patients. Now, if it is angioedema, which is a little bit more serious and life-threatening in some cases, most people are hesitant to use ARB, and we just say, you know what, forget it. But again, to bypass those, I always just, recommend go with ARBs as you start. Since we know they are both equally effective, there's never really been a head-to-head study, to be fair, but we know that they offer similar protection for the heart and the kidney. So we go with ARBs, especially also for African American type 2 diabetics. Again, that's because a lot of the studies in type 2, for instance, diabetics are mostly with ARBs. So it's really the type 1 people. Then there were no ARBs per se. And so ACE was what was used during those earlier studies back in the days. So, but because of the issues with ACE, also in Asian population, they have this ACE polymorphism. They also have a relatively high risk of lack of efficacy with ACE and also some kind of reaction. So it's just always better to start with ARBs for that reason. Now, having said those, if you're not able to use ACE or ARB, there's still an option.
Sure.
Spironolactone. Aldactone, because it's a continuum of a system, it's the RAS, the renin, angiotensin, aldosterone system. Spironolactone is, I believe, is underutilized by both cardiologists and nephrologists, but mostly cardiologists. If we're not able to use ACE and ARB, spironolactone have shown a lot of promise. A lot of people will argue that they are somewhat equivalent to either of the ACE and ARB alone, and they still offer that protection if you're not able to use ACE and ARBs. So, but go with ARBs first, and then you can bypass that whole ACE allergy labeling of your patient. If they come to you with ACE allergy history and you're able to clarify that it's not angioedema, I will still go ahead and challenge them with an ARB.
Yeah, thank you so much. Ali, I think you wanted to make a comment on that too. Go ahead.
I'll tell you this. One of the beauty of science and technology and innovation is that we keep moving and we keep progressing. Down the road, there's a whole lot of people in that space already, but it's still not widespread. Where they begin to talk about precision medicine, where they take your blood sample, run it, and see what blood pressure will be really good for you as a person, as compared to other. Because we have different medications and different meds of the same group that you can give. Now, I guess what? Even within the same group, some medication work better for some people as compared to others. And we'll begin to see that. Now, when it comes to the ACE inhibitors, which are for those who are not in the medical field, we're talking a little technical right now, the ones that ends with the PRIL, captopril, enalapril, all the pril, and those are blood pressure medicine that that they give to our people. So, but watch, if anybody will learn anything out of here today, at the end of the day, go take your medication and see what you're taking and look to see what it is. No, it's important, because that's one of the things I often ask people. I say, what meds are you taking? They're like, doc, it's there, you see. I'm like, no, I know. I want to see which one are you taking? Do you know what you're taking? I said, guess what? You're the one who's putting it in your mouth. You're putting it in your mouth, not me. So if you don't know the medication that you're putting in your mouth, then there's a problem, because you need to know. You need to know the dose, you need to know what medication and possible side effects. But one of the funny things that I often heard people like, if I prescribe the medication, the person is like, doc, what's the side effects? But then they don't know the name of the medication. So it's so funny. But coming down to the ACE and the ARBs that we're talking, and this is very serious, I'm beginning to observe a few things. Now, ACE inhibitors, according to PubMed, said that I think about 40 million of those medications are prescribed every year in this country, according to PubMed. And the angioedema, meaning the swelling of the lips. Now, you cannot tell who will have the angioedema. It can begin with the first dose. It can begin 20 years after. There's no real, you can tell that. So once somebody is on those medications, outside of the cough, you see the lips get swollen, either at the top or the bottom one. And it's dramatic to the point that people, get really afraid. And if it's really bad, it begins to get them, respiratory problem. Now, if you have that, you need to go to the ER or call your doctor immediately. It's usually frightening, but if you call your doctor, he'll be able to handle it. He knows what it is. They'll ask you what medication are you on. Now, in the US, about they said 100 people go to the ER every 100,000 people go to the ER every year because of that, and that's really significant. Now, so in my practice, what do? I'm really cognizant of that, but what I look at again is this: if you have diabetes, and I see the protein in the urine, because we need to gain. That's another discussion: how to protect our kidneys for those who have diabetes or who have high blood pressure. Because again, for Black people, it's really different. We need to learn how to do that. Now, how do I prescribe it? If you have diabetes and you have high blood pressure, I may look and I ask around, anybody with any abnormal reaction to medication in your family? Because sometimes it runs in family, you can't tell. Have you ever had any of those before? They say no or yes. Then I'll say, okay, you know what, let's try. But I'll tell you, hey, if anything goes wrong, this is what it is. In my experience, it's very protective. Because I've seen over the years where I check for protein, the protein will be 1,000, 2,000. Once you put them on those medications, you check again 3 months, that 1,000 drops to 200 or 200 and even less. It's really protective of our kidneys, especially for us. Now, for those who I have a concern, I'll put them on app. However, the teaching is this: if you have cough with the regular ACE, you can use the other app. But if you have had angioedema, the lip swelling and all that, then you have to stay away from even the app itself, because 15% of those who have allergies to the first medication also have angioedema risk. And that 15%, you don't want to take the risk. So, but again, that's what we do. However, for our people, I noticed one thing. Among the apps, recently, I don't know if something's changing or whatever, for those who are on apps like losartan, for those, look at your for those who are losartan, I begin to realize that their blood pressure is not as well controlled. So now I begin to switch all of them to valsartan. And I see valsartan is doing so well for our community. I don't know why. I'm sure there's a reason. Maybe down the road we'll find out. But this is what I'm finding out right now. And it's important that, above all, you have to protect your kidneys and you have to bring down that blood pressure, because those two things are really, really important.
Thank you. Thank you so much. There's a study, I don't know if you all have seen it, that, actually compared blood pressure medications across races. And it was shown that for our people, diuretic, that's water pill, we call it water pill, and what we call calcium channel blockers, things like the pins, amlodipines, and all, are better for our people and for older people, regardless of race. But the ACE inhibitors actually does not control blood pressure well in our people in that study. And but it's good for that, the bottom number, the diastolic pressure, generally. So especially after hearing Dr. Ezegun talk, I usually start with ARBs in our people. Thank you so much for, all of you expatiating this. But Dr. Simon, I wanted to ask you about the spironolactone. Do you worry about potassium retention? And would you put the patient on a combo of hydrochlorothiazide? That's another water pill that, pulls out the potassium to balance things out. Do you worry about it with kidneys?
Yes, that's a great question. And before I actually touch on it, I will just talk a little bit more what you talked about. The thiazide diuretics, they remain the drug of choice for blood pressure control among Black people. Now, I know Dr. Aluya likes anthropology, and he mentioned a few earlier. From where we come from the part of the world where we come from, Africa, it was said that back then, when life began there, access to water was not easy. And so the body needed to find a way to be able to conserve the host by conserving water, so we don't get dehydrated. People will have to walk miles and miles and miles before they can access water. So what the body then did back then was that, this is the theory, the kidneys found a way, the kidneys of Black people found a way to be able to reabsorb sodium so well so that that person does not get dehydrated until they eventually get to water. Now, this became part and parcel of a Black person's kidney, so that even when Black people migrated from Africa, and now in these temperate countries, our kidneys still retain this innate ability to reabsorb sodium effectively. And that's why high blood pressure in Black people is tied to sodium and water retention. And this is really why those diuretics work so well for us, especially the thiazide, when it comes to blood pressure control. Now, so that's the little science behind that. Now, when it comes to spironolactone and high potassium, the risk with spironolactone alone is equivalent to that of either the ARB or the ACE inhibitors alone. It's not higher. So if from potassium perspective, you're happy to do ACE inhibitors or ARBs, you can also do spironolactone without incurring other additional risks. Now, there are people where we've had to add spironolactone to ARB, for instance, or to ACE. Now, when you add that, then your risk of high potassium level becomes a problem. It increases more than twofold, actually. So yes, those are the anti-proteinuric benefit, like Dr. Aluya was talking about, and the heart protection and the kidney protection also increases. So if you have a peculiar patient that has a lot of protein in their urine, or has such cardiovascular risk or renal risk, and you need to give both, like aldactone on top of an ARB or on top of an ACE inhibitor, and you think they will benefit from it, you may need a potassium lowering agent. And yes, adding spironolactone with something like a thiazide or other diuretic, or like furosemide, that can lower correct potassium is key in cases like that. But if you're just using spironolactone alone with a normal or good GFR, meaning your kidneys are good, the risk of hyperkalemia is very, very minimal, not any higher than if you are using ARBs or ACE alone. Thank you.
Thank you. Thank you so
Except-
much.
except that some men don't like it, though.
Dr. Aluya, 1 minute. Dr. Izugu, go ahead, sir.
Yes, please. Yeah, thank you. Thank you really very much for those comments. Now, the thiazide diuretics and the calcium channel blockers, that is true, they do lower blood pressure, but they rev up the RAS system that destroys the end organs. So in managing these conditions, we really have to approach it where we protect those organs and then combine it with other medication to lower blood pressure. So really, it's very, very important in putting an ARB or aldosterone antagonist type of medications to really protect those organs. Now, yes, invariably, we may have to add a diuretic to balance out the potassium. One thing, again, why I really keep hammering this, especially for our large audience that deal with a lot of African-American patients, is that once they are said to be allergic to ACE inhibitor, these patients will end up on dialysis. Their heart failure management, none of the heart failure medications can be given to them. And we deal with this because nobody want to be going to answer questions. So we should really begin from the early beginning in end organ protection, going towards ARBs on these patients. And then, of course, aldosterone antagonists and all that situation, whatever we're gonna do, but whatever we can do to avoid, end organ failures. And then the diuretics or calcium blockers can be added on top of all this to lower the blood pressure. That would be my, my comment on this area, please.
So end organ damage, meaning, damages to organs like the kidneys,
is the heart.
the heart.
Yeah,
the
even
liver,
blindness.
that's
all of
what
this.
end organ damage means. And these medications we are talking about are protective of them. So even if you don't remember, and you have diabetes, when you talk to your doctor that I'm on that medication that protects my organs, the doctor will get it. And that may spoil your doctor to look at your list of medications again. None of us is perfect. And doctors see lots of patients. It doesn't hurt to jolt somebody's memory in a nice way like that. They will look at your list of medications and be able to see what needs to be added or removed. So that's a good way to approach that. Thank you, Dr. Izugu.
Thank you.
That. So iPhone, that's doctor again. Oh, this is iPhone XR. You can unmute.
Thanks.
Can you introduce yourself, please? Because it says iPhone.
Yes, Dr. Kaya the Major.
Dr. Kayode. Oh, yeah. I'm meeting you right here.
Yes, that's Dr. Kayode I was telling you about.
It's a pleasure meeting you.
Yeah, pleasure meeting you.
Thank you, Sister Rosemary.
Yes, that's right. Pleasure meeting you. So I do want to clarify something about the diuretics. The diuretics used particularly for the sickle cell patient population. I understand that it should be avoided as a blood pressure control agent because of the tendency to cause dehydration in SS patients. Because you need as much water hydration as you can in SS population, and giving a water pill for blood pressure control actually can send you into a bad crisis. So that's one experience I have personally had in the past, and I just want to pass that on. If you happen to be an SS sickle cell person that's struggling with high blood pressure, you may want to be sure your doctor is knowledgeable enough not to prescribe a diuretics, because it could send you into the crisis from dehydration. And then next thing you know, you have organ failures and things like that. Some doctors are not aware of that, but it's something to clarify, to look out for. Yes.
If I may add to that.
Yes, yes, Dr. Aluya, I'm going to.
And that's why it's important that you seek doctors that look like you, eat like you, and believe in the things you believe in, period. I mean, studies have shown that if you're taken care of by people who look like you,
that's right,
you're more likely to live longer and a better outcome than anybody else. And then guess what? A new study came out a month and a half ago, New England Journal of Medicine says that if you live in an area with doctors who look like you, you do better than when you live outside the area with doctors who don't look like you. These are studies, again, they are real. Now, coming to sickle cell, I'm sure Dr. Simon will talk about that a little bit. When you talk about kidney failure, that people end up with kidney failure, there are different types. The APOL1 gene that we talked about often results in what they call focal segmental glomerulosclerosis. It's a different kind of breakdown of tissue that results in kidney failure. There are a lot of other diseases that lead to that. Hepatitis C, HIV, sickle cell is one of them. You understand? Now, there are other types, that's the membranous type, and the other one, glomerulonephritis and all that. The membranous type, where the kidney gets bigger and swollen, this is more from diabetes. Now, talking about sickle cell, if you take the average size of a normal person and a sickle cell patient, now the sickle cell's kidney is a whole lot smaller than the equivalent age of the other person because of repeated infarcts that have taken place over the years, whether big infarcts or small infarcts. So the usually is smaller, and the tendency for it to depreciate and end up on dialysis is really fast. However, if you take the kidney function of both a sickle cell kidney, it may look normal, but that is an abysmal normal. It's not the typical normal function that you get. And that's why for people with sickle cell, you gotta be really careful how you manage them. But in my experience, I've realized that putting them early on an ACE inhibitor, the same one that we talked about, is renal protective as well. Because as early as possible, you screen them screen the urine and see if there's protein. But better off, now with technology, we can screen for microalbumin. So when you check up before it becomes protein, you can see those tiny albumin. So if there's anything will from here today, please, when you see your doctor, tell them to check if there's protein in your urine, because it's important. Those are very, very early signs if the kidney is going through some damage. So again, you check for microalbumin. If it's there, you put them on ACE inhibitors. It really does help protect. And like you said, anything that make the kidney lose water, sickle cell patients, is usually not good.
Yeah.
Thank you so much.
Thank you.
Thank you for openly asking that question. I respect it. Thank you. It's a pleasure to have met you. We have lots of questions in the platform, and on Medical Mondays with Dr. O, we answer all the questions. So I would suggest that we, answer those questions straight up so that we can run through them and, be able to summarize. So a question is, what are the foods to avoid besides alcohol? And of course, if you want to raise your hand to ask your question, you can still do that. So, Dr. Simon, what are the foods to avoid besides alcohol? I saw this question earlier. It was when you put up the foods that we should eat. You put the foods we should eat up there, and I saw the wild salmon. I wanted to comment on that. That's fantastic. So what are the ones we should avoid?
So when it comes to the kidneys, if your kidneys are healthy and normal, and your GFR is at least above, let me say 30, so you have at least 1/3 kidney function, that kidney should relatively be able to deal with whatever you eat with relative ease. Now, we start to talk about avoiding certain things when your kidney function is so poor, and now we're trying to give it less work to do. So part of what the kidney does is to help us eliminate toxins, like we said. Majority of the toxins that we cannot get rid of except through the kidneys are some kind of acid that we generate mostly from animal protein. So if you're a lover of meat, red meat especially, you generate a lot of phosphoric acid, sulfuric acid, and amino acid derivatives that the body has no other way to get rid of it except through the kidney. The more of those kind of food you consume, the more work you give your kidney. And just look at it this way. Dr. Aluya just mentioned something that when they could check your kidney function, it can look good on the paper, but you have to understand what the kidney is doing to make it look good. Your kidney could be racing, and the blood wall looks good, but the kidney is racing because you have plenty of protein in the urine, or you have a lot of acid in your generation. So the kidney is working overtime to make your blood work look good. But years down the line, it's gonna get tired faster. So if I ask you, when do you get tired quicker? When you're running or when you're walking? It's when you're running. If you're running, you can run 5 minutes and then you're tired. If you're walking, you can walk 1 hour before you get tired. So you want your kidneys to work. And that's sort of what these medications also do, the ACE inhibitors and the ARB and all of that. So food that are rich in animal protein, not so great for the kidneys, especially if you have lower kidney function. Then if you're getting close to dialysis, or already on dialysis, this is where we really clamp down on diet. Potassium-rich food, phosphorus-rich food. Examples of high potassium food will be like, potatoes, mangoes, watermelon. They are good when they are healthy, but when the kidneys are bad, then you can easily accumulate potassium and run into trouble. Then processed food generally are not good. So if you can keep your meals as natural as possible, I know it's harder said than done, especially where we live, but less processed food, because a lot of the processed food are rich in phosphorus and uric acid and stuff like that, and these are not good for the kidney. So the closer to natural with whatever you're eating is, the better for your kidneys. I hope I've been able to answer. So there are peculiar situations. You can have a genetic abnormalities, for instance. We talked about G6PD deficiency, for instance, and where you have to avoid certain things. Licorice is a supplement that some people snack on. It's not too good, but because it can promote water retention in the kidney and hypertension that can damage your kidneys down the line. So it's hard to list all the food. I would say when you talk with your doctor who knows you and they know your family history and genetic makeup to some extent, they can guide you further on specific food that you should avoid. Thank you.
Thank you so much. Dr. Aluya, do you have a comment on that?
No, he did justice to it.
He killed that. He killed it. So thanks so much. Someone said this is educational. And there's a question here that says swollen calf and foot on left foot. This is quite interesting. That's all it says. So your foot is swollen and it's only the left foot. It's not kidneys. Is it kidneys, Dr. Simon? I should ask.
Usually not. If you have a swollen anything on only one side, because the kidney typically is a systemic disease. I saw someone type the question that if one kidney is damaged, how long does it take for the other to be damaged? But the answer generally is if there's something in your body that's damaging one kidney, that other one is also getting damaged, or almost at an equivalent rate, because it's it's blood supply to each kidney. If you have a swollen one part of the body, it's unlikely to be the kidneys. So you should probably check it out for other things with your doctor. Blood clots will be what comes to mind first, and trauma, other things like that.
Thank you. So please elaborate on the foaming in urine when you urinate.
Yeah, if you urinate and there's a lot of bubbles, it could be a sign that you have protein in that urine. And so you should get checked for that. Because if your urine has protein in excessive amount, more than what's recommended, that kidney eventually will become damaged, just like Dr. Aluya has said. And it is irrespective of what the cause of that protein in the urine is. It could be coming from anything. But as long as there's protein in your urine, that kidney will eventually get damaged. So you should take that very seriously. It's typically one of the earliest signs of kidney disease. And if you check it early, you can get a chance that it gets treated and you stop that kidney damage and you don't get to dialysis. So take it seriously if you see bubbles when you urinate, excessive bubbles.
Thank you. So both of you, I want to tell you, please jump in. Dr. Aluya, Dr. Simon, I'm not going to call on either of you.
I'll tell you this.
Thank you. Jump in.
I've had a few people who, the biggest, very first concern, and I tell people this, if you find out that both of your feet are swollen, it's an issue. You cannot let that pass. If it happened this night, you woke up, when you go to bed, it goes down, and you wake up again, both legs are swollen. there's something going on. Those are very early signs that your body is warning you of something. Now, for both legs, Dr. Simon said if one leg is swollen, it's usually one, meaning it's only limited to that one leg, meaning unilateral. But if both, it therefore means it's systemic. So it's something that is both. So 4 reasons why your four reasons why your legs could be swollen. 1, if you take it from top to bottom.
Wait a minute, leg.
Yeah,
Both or
both
one?
legs. Both legs.
Both
Yes,
legs.
both
Okay,
legs.
thank you.
So the number 1 cause from head to bottom, it's your heart. It's either the heart is not pumping properly, so the fluid is not going back to the heart. So there's a backlog, and that's a very early sign. It may be your heart. 2, it may be the liver. Again, because the liver is responsible for producing albumin or protein that keeps the fluid within your vessel. So if the liver is failed, sometimes usually the signs and symptoms, if the heart is failed too, there will be signs and symptoms, or something very early, that again can be a cause. Now the third one is the kidney, meaning the kidney is not, perfusing, is not excreting the water, the fluid out of you. Now, those are very common causes, but they can be sometimes, not that common. But the number 1 common cause is usually medication. Medication is usually the very common one. And the medication that we know is usually the calcium channel blocker. For those again, look back at your medication cabinet and see what you're taking for blood pressure. Amlodipine is number 1 culprit, amlodipine. And again, you cannot tell when it starts. It may be you take it 2 days, your legs are swollen. It may take it a week or 2 years, then your legs start swollen. We can't tell who that would be. So hopefully as science progresses, we'll be able to analyze everybody's blood and see which one works for everybody. So that's the number 1. So if you have both legs swollen, look at your medication cabinet or call your doctor and see. And that's the first thing the doctor will look at. Are you on these meds? And they said, okay, no, it's not. However, another drug that's not really well spoken about that can result in it, again, 2 other drugs. One is gabapentin. Gabapentin is also notorious for making you retain water because of one of the other mechanisms that it does. And then in very rare cases, metoprolol can do that, especially if you have a heart that's not as functional as you ought to be. So the first thing you look, medication, call your doctor, discuss it with it. And if there's anything, go ask your doctor. He will send you for tests, check your urine, check your kidney function, check your heart out and your liver.
Thank you so much. Leg swelling is indeed important. It's just that if it's one leg, thank you. It's been addressed. And I hope that question was answered. Is it a bad thing if your kidneys metabolize things like asparagus in about half hour? I don't quite understand that question. I know that Dr. Simon talked about asparagus.
Yes, it is not a bad thing. What comes out of your urine is just a reflection of what you put in your mouth. And so the fact that you can actually smell that and feel that quickly may show a sign that your kidney is doing what it's supposed to do adequately. So that by itself is not a bad thing.
Fantastic. Thank you. Fantastic. Apart from water, can a person drink ginger water, grated ginger root in water, specifically? So this is not the sugared ginger water that you buy in the store. This is somebody making their own drink. And will this affect any other medications one is taking?
So, there's a whole lot of talk now about ginger and I lost count. And people actually buy the pill, they order from those GNC products. And now, while the research are not overwhelming in this, and those parts are not typically well funded, this is what I tell my patients. Just water, as we know it, is the best. But some people say, I don't like water, and they would like to flavor it. Okay, if you're going to use natural ginger, it seems okay. But I say, whatever you do, just do it with these two things in mind. Number one, moderation. So if we tell you it's okay to do ginger water, then don't flood yourself with ginger water from morning to night. Anything done excessively can be potentially bad. That's one. Two, once you start a new habit, either a new product, a new supplement, in about a month, 2 or 3, try to get your blood test done by your doctor just to make sure the organs are doing okay with it. So if you go by these two rules, you're unlikely to cause significant damage, because if something were to happen, you will pick them up very early. It's very hard as scientists that we are to recommend certain things that have no landmark study with benefit, and people come on TV and they swear by this and that. I won't stop you, but I say, get your blood checked, make sure your body is tolerating it. 2, if I have specific information about a compound and the kidney, I'll let you know. And 3, moderation is the key. Thank you.
Thank you.
Yeah,
Dr. Leah, any comment?
Too much of everything is bad, period. Too much.
Okay. On that note, how much water should should you drink to flush your kidneys? Yeah,
well,
answer that.
I'll let Segun, answer those questions. With regards to taking herbs, because our people are so good at herbs, because they're like, oh, it's natural, everything's natural. But I'll tell you this, first and foremost, when you pick up that bottle and it's a herb, for God's sake, please look to see where that bottle was made and by whom, by how, and where. And you can look it up if there's any recall. The problem that we have, you see, with regular medication, if there's a problem with those medications, the contamination and all that, there's a recall. With those herbs, you tell me, has anybody ever heard that there's a recall in any of the herb? None. Nobody knows. So how much damage is it doing to people? Nobody knows. Nobody's doing any study. Nobody's following. So if there's a damage to you, you will suffer that damage by yourself. Now, I've always said this. There's a study, there's somebody who reported issue one time, and it was a herb. They were like, oh, it's good for the spirit, it's good for the soul, it's good for this, the joints and all that. And then they took a picture. The picture shows that the factory is in Panama. Now, when something happened, but guess what? When they researched, that picture that shows is in Panama and all that is not truly from Panama. It was somewhere in Southeast Asia. And God knows, you don't even know who's concocting those medications, those things that you talk about that they're concocting. You don't know what it is. And there's a recall, there's not. So always be very careful. Because it's good for Mr. A doesn't mean it's good for you. And I always use this analogy. Billions of people eat eggs every day, right? Eggs are good. But guess what? Some people eat egg and they end up in the ICU. Does that mean eggs are bad? No, it's just that it's bad for you. How do we know which one is good for you? We don't. So in as much as you want to start something that somebody else is doing is working for them, please look it up, do your research, and you can bring it up to your doctor. Let them sit with you, look at the ingredients of what was reported, and then compare if there's any interaction with the medication you're taking so that you can safely take your medication or whatever herb that you want to take. Thank you.
Thank you. Excellent. If I may add really quickly, as Dr. Leah said, I've heard many people tell me, I don't like medications. I don't want to take medications, but they take capsules and tablets they buy that are naturopathic medications from, special stores. These medications, to be made into capsules and tablets, have what we call fillers. It's the same thing that we prescribe in medications that are fully researched, that they use, the side effects and all, and it's fillers also they have. So you are taking medication when you're taking these supplements from these stores. It's just that they are not researched. And it's been shown that some of them in the same bottle would have 100% of the core ingredient, and some would have 0 or 50%, not in the medications we prescribe. It has to be the same in every pill or every capsule. It must be, because it's what the FDA approved. So we need to be careful. Thank you, Dr. Luya, for bringing that up. I think we have to be careful with these naturopathic things. The question on if one damaged kidney accelerates or affect the functioning of the second one has been answered. Dr. Duyebo, if you're not clear on that answer, kindly, prompt me or raise your hand so it can be addressed again. So another question says, please comment on toxicity from frequent use of pain medications, even as common as Tylenol, ibuprofen, and other analgesics. I love that question. So comment.
Hello, can you hear me?
Yes, we can hear you.
Okay, so this is really key. So in the world, when it comes to medications and kidney damage, the non-steroidal analgesia rank, we believe, number 1. Okay, the literature is telling us that PPI, the proton pump inhibitors, all your omeprazole, pantoprazole, probably maybe.
You are muted.
We can't hear you. You're muted. Okay, you are muted.
Hello?
Okay,
Okay,
now we can hear you again.
Yeah, I'm so sorry. I had a call coming on my phone, so it
You
it
are
took me off.
popular. Thank you for your time. Thank you for spending time with us.
Yes. So the PPI and the literature are ranked higher. That's just because it's so widely prescribed everywhere. Almost everyone is on PPI. You get admitted, GI prophylaxis and all of that. So, but NSAIDs are big, big, big. I don't know any medication that has caused more damage to the kidney than pain medication. And it is widely available without prescription. People can buy Aleve, ibuprofen, Advil over the counter in this country. Well, in Africa, of course, you don't even need a doctor to buy probably anything. Now, I will scare you a little bit. In extremes of cases, I have had a patient took 1 dose of ibuprofen, 800 milligrams, and needed dialysis. 1 dose. That is how serious it can be. Now, this is an unusual reaction and a little bit extreme. The majority of the cases of kidney damage coming from these pain medications are chronic use, chronic frequent use, especially daily use by people who just need it for some kind of pain control, back pain, knee pain, headaches, and all of that. I tell my patients, once you have your blood function checked, your blood test, and your kidneys are okay, and you're on all of these medications, painkillers, make sure you keep checking them every 3 to 4 months. So if there's any early sign of damage, you can quickly stop it. The best way to use pain medications is not to use it consistently. So I would say in a week, if you can use it 1 or twice, so that gives your organ time to recover from each dose that you use. That way, you're able to keep those organs functioning longer. So, but we really, really, really need to pay attention on popping pain medications, especially without supervision.
Thank you. Thank you. By the way, Dr. Aluya, you have missed, and people are commenting on that and on the platform. So, what is pyelonephritis? It's a question.
Pyelonephritis is simple. It's an infection that is involving the kidney. Usually, it's a bacterial infection. Commonly starts as a urinary tract infection, all the way down, gets up to the bladder, and then moves all the way up to where the kidney is. Once an infection involves the kidney, bacteria most of the time. It could be anything else. It could be fungal, it could be viral, but most of the time it's bacteria. Once it involves the kidney, we call it pyelonephritis. If it's just limited to the bladder, we call it fantastic. This is a good slide. See, you see the urethra all the way down. That's where the urine comes out. And that's where most of the time bacteria gets introduced into that system. If it's not checked or treated early, it moves up all the way to the bladder. And then it stays in the bladder, then we call it cystitis. That is when it involves the bladder. Now it can, if it's not checked, it can climb up through the ureter and gets all the way up to the kidney. Once it involves the kidney, the bean-shaped organ, the two of them that you're seeing, it may involve just one or both, then we call it pyelonephritis. This is the common way it happens. Occasionally, you can get pyelonephritis directly from a bloodstream infection. So let's say you have infection in your blood and the blood is flowing everywhere, and then it gets to the kidney, it gets seated there, and you have pyelonephritis as well, without it arising from down below. I hope this is clear. Thank you.
Thank you so much. Dr. Veronica, you can unmute and ask your question. Dr. V, all the way from California.
Oh, I guess, thank you, Dr. O. I'm so excited that many people got this information, 100 people full on the platform. I was almost going to step out to go do something. I'm glad I didn't. I wouldn't have been able to come back in. But I just really appreciate what you're all doing. I know that our population is full of people with kidney issues, maybe also high level of people I talk to that have high blood pressure, that they have those two things. What can we do with, and they have the high blood pressure and then the diabetes. And a lot of our children are living the best they can of living healthy, maybe even joining gyms and things like that. But what can we do to really get this information across to those who aren't here? I'm worried that this is happening a lot in our community. You even said it. This is kind of a SOS. Dr. Aluya, he shared information and many of us are like, what are we going to do about it? And within less than a week, you talk to Dr. O and you are here. People are desperate for this information. What can be done? Dr. O, Dr. Aluya, all the doctors, Dr. Segun, we need to get this out to the community. How can we summarize this? Many people couldn't get in. Thank you.
Excellent point. So it's on YouTube. The whole program tonight is on YouTube. It's being streamed live. And you know what? Some forces knew that it's so important and needs to be streamed that I almost couldn't get on YouTube. It didn't make sense, but we did. So it's streamed live. It's also on Facebook and people can access it that way. What we would also do which you are going to do, like you have promised me, is put this information in short, succinct,
I definitely do that now.
And then, and we can put that out so that people can get the core of information really quickly. So we'll work on it. And you're right. Thank you. I love it. We need to be concerned for our people. That's why we're here.
We love you. Thank you.
Healthy. Love you.
Love you.
Dr. Aluya, I can't believe you're raising your hand. You co-host tonight.
Yeah, I'm raising my hand because I'm going to ask questions.
Be careful, I'll make you permanent co-host.
No, Doctor, I'm asking the expert a question.
Yes, we support it. Permanent co-host.
Thank you. That's it. That's it.
Yeah, we miss him a lot. So it's good to hear him.
See?
Now, Dr. Segun Simon, one of the big issues, a lot of times our people go to the ER, and they go to the ER, and before you know it, they have a barrage of tests being done on them, including CT scan. And a lot of times they do CT scan and they give them contrast. What is your view of use of CT contrast because a lot, I'm sorry to say, but when you go for Qatar, whatever, the next thing they hook you up to the machine and you're gonna CT scan of your chest on the whole body. And at the end, they give you the scan. Sometimes they don't even look to see if how functional your kidney is. And we've had a lot of our people in the community end up with acute kidney injury and eventually chronic kidney disease. So what's your advice in that? And how do we begin to protect ourselves with that as well? Thank you.
That is crazy.
Ah,
That
that's an
anybody will
awesome-
give contrast without knowing the kidney function. Dr. Simon, help us with that too.
Yeah, that's an awesome question. So contrast associated nephropathy, that's what the name is called now, CAN. It is real, it exists. It was debatable for many years. I have seen it in practice, you know. So there are certain risk factors that make people more prone to it. And the number one risk factor for that would be an underlying existing chronic kidney disease. So if you already have an existing kidney damage, you're at the highest risk. If you have proteinuria, you're at risk. Then if you have diabetes and heart disease and all of that. So if your kidneys are normal, relative good GFR greater than 60, the risk is very minimal and probably non-existent. So we deal with this when you have already CKD. It is crazy, if you permit me to use that word, like Dr. O said, that any ER in this country will subject a patient to an IV contrast without knowing what their GFR or their serum creatinine is. It's very unusual. Even in an outpatient basis, I've seen when you send people to go get a CAT scan, you have to either write the creatinine on the script, or I typically send them along with their chemistry to tell the radiologist what the kidney function is. And sometimes I put a little note and say, hey, this is a kidney doctor, patient is cleared, can have contrast. So I'm not so sure that it's a widespread practice in the country to subject people to a CAT scan without a creatinine. Now, even in cases of very young patients who seemingly look healthy and all, and have no medical issue, and they are there because they had an accident or some minimal complaint, I think most doctors in the ER or providers, we still first want to see what the GFR is because it's a big, big, big risk. So this will be my comment on that. But it does exist and it is real. I see it, and we should be careful with that. Thank you.
Thank you. So is there any natural food you can eat to help clean the kidney?
Water, hydrate.
I love that.
Fruits, vegetables. And part of the reason they are good is also because they have a higher content of water. So the kidney is always happy when you hydrate. I know that you asked a question earlier, how much water should we drink on a daily basis? I've always tried to answer this question a bit in a political way, and I will tell you why. It's influenced by so many factors, by how much sodium you consume, because if you eat a salty food, generally you're going to be thirsty. And you're going to want to obey that thirst by drinking more. The level of your activity during the day, the climate, the weather, you know, in the summer, we get more thirsty than in the winter. That's just because there's more insensible loss of water. We are more prone to dehydration in the summer. So it's hard to say, drink this amount every day for everyone. It's not a one size fits all. And I tell people I go by this logic. See, when God made us, if you believe in him, I certainly do, he made the body perfect. If the body needed water, it will call for it. You will be thirsty. So if you are not thirsty and you drink a liter of water right now, and you're not thirsty, an hour later, you're going to the bathroom to go pee. Guess what? It's the body saying, I didn't need that water, so I'm getting rid of it. So if the body needs water, you will be thirsty, you will drink, the body will hold on to it. So I say, obey, listen to your body, follow your thirst mechanism, and if you answer it proportionately, accordingly to your satisfaction, you shouldn't run into any trouble. So some days you drink more because the body needed more based on all these factors I've mentioned. Some days you will drink less because the body needed less. Thank you.
Fantastic. Thank you so much. I've never heard anybody put it that way. I will live by that going forward. So there's a question that could you kindly leave information on your advocacy work for people and patients looking for personal advocates? Do you have an advocate?
That would be for Dr. Aluya.
Dr. Aluya, you have an advocacy work?
Sorry, I didn't get the question.
Could you kindly leave information on your advocacy work for people and patients looking for personal advocates?
Oh, well, yes, we do have. Well, one of them is join NAPAC, that's for sure.
Yay!
That's where
and you know what? Join NAPAC. Thank you. I know the doctor who wrote this, Dr. K. She said, sign me up for advocacy work.
NAPAC, yay.
And Dr. O happens to be the chair of the medical committee of NAPAC. So
I am.
That's where the advocacy begins from as well. And so that we can push the narrative to where it needs to go to. There are other avenues as well. I belong to a group of Black doctors, where 12 of us, from cardiologists to neurologists and to psychiatrists and neurosurgeons, orthopedics, where we talk about medical and medical related issues every second Saturday of the month. And that's on Physician Health Network. Dr. Simon is also one of us as well. So that's some of the other platforms that we do this. So you can type up Dr. Segun Simon name on YouTube or my name, and you're going to see some of the things we've done. Dr. O, you see some of the things we've done. And if you want to reach out to us, you can always reach out to Dr. O or to through NAPAC, and we'll help conscript you. This, if you pardon me, use the word, so that we can push the narrative up for us. Thank you.
Thank you, Dr. Aluya.
NAPAC, NAPACUSA.org. Yes.
I'll put it in the chat box. Auntie Angore, you have your hand raised. Go ahead, ma'am. You can unmute. You can unmute.
I want to ask if all those vitamin supplements like vitamin D and folic acid, do they affect the kidney after a long time of taking? Yeah, thank you.
I'll leave it to the experts to answer that. But Sister Ngore, I'm going to ask you to unmute ready. Wonderful. Sorry?
I don't know what's going on with me.
Okay. So vitamin D and supplements, do they affect kidney function is the question.
Where's Dr. Simon? Is he still there?
Okay.
Sorry, I'm here. I think I missed, I was attending to something real quick. I missed the...
Okay, so we have a question that we're answering. If you please hold. Thank you. Dr. Simon?
Yes.
Vitamin D and other supplements, do they affect kidney function?
Yes. Again, the key here is to start from what's your kidney function like. If your kidneys are good, like I said earlier, it's able to deal with almost whatever you throw at it. Now, that's for most supplements. With vitamin D, it happens to be one of those vitamins that has the ability to accumulate, and we can go into toxicity. If you remember how it's metabolized, there are some vitamins, for instance, that the body can never accumulate, even if you keep taking more and more. But in the case of vitamin D, you can overdose, let me put it that way, because it can accumulate in your body. If you have excess of it, it can lead to too much calcium absorption, and too much calcium in your system can lead to some kidney issues, either by causing kidney stone or by causing some level of dehydration and kidney damage. So theoretically, the answer is a yes with vitamin D. How often do we see this in clinical practice is very rare. But again, the key is for everything moderation, and to get your blood checked routinely, at least yearly if you're healthy, every 3 to 4 or 6 months if you have a medical condition, and we can always pick these things up early. Thank you.
Thank you so much. We still have quite a bit of questions. I'm going to just run through what I think have not been answered. And yeah, preference to Mary, you can unmute and ask your question while I flip through these ones in the chat box. Okay, so is...
Oh, can you hear me now?
Yes, we can.
Oh, okay. So I just want to quickly add about having yourself checked and knowing your numbers or whatever your kidney is doing. I'm going to cite myself as an example real quick. I had a lab, I think it was a month or 2 months ago, and I came to find out that I have excess vitamin D and vitamin B. And my doctor had to tell me that I should stop taking vitamin B. And most of the people that I see, I know they have all these vitamins and they never go to check anything. And I also had a patient, I forgot the name of the medication he took, and he was on dialysis right away, just one medication. But from what Dr. Simon said, I want to believe if he had an understanding of his prior kidney function, he would have been able to avoid that. So my greatest advice will be, please let us go see our doctors or our practitioners or our primary care providers and know your numbers. That is the power we have, and being proactive about our health will be the best way to prevent all these diseases and to help ourselves as well. Thank you.
Thank you. Thank you. So what if you urinate 4 to 5 times at night? Does it mean that you have kidney problems? Dr. K say, wouldn't it be nice to get frequent flyer reward miles for that? But does it mean you have kidney problems? Dr. Aluya, kindly answer that question.
Well, I'll say it in this way. If you wake up more than 3 times at night to pee, it's usually not a good thing. It's a sign of something going on. Now, 2 reasons why people wake up multiple times to pee at night. One, if it's a male, then sometimes it could be, prostate issues. Usually in the 40s and above, they tend to have that. And with that, they have as well with it during the daytime, what they call prostatism, meaning you want to go pee. Once you went there, you get to the bathroom, you want to pee, the pee is not coming out because the prostate has gotten big and has obstructed the urethra from it going. So you have to stay there and wait and force it, and then it comes out. Now, once it comes out, the stream that used to go boom one time no longer goes that fast. It's now slow. It's dribbling. Then that's the problem. And you finish, you've done, and you want to go, you still feel like, you still feel the pee again. It's called incomplete emptying. So that is another reason why some people would have problem peeing multiple times at night or in the daytime. Now, there's what they call the true saw instability, meaning the bladder is very sensitive, either from infection or something, or you ate or something somewhere, very sensitive. When urine touches the bladder, it just wants to expel it. It just goes, hyperactive. They call it hyperactive bladder. So sometimes it can happen like that. There are medications to help, do that. But the most significant and important one is if you have diabetes. If you have diabetes and you're waking more than 3 times to pee, it is just shows that your sugar is uncontrolled, period. If you wake up more than 3 times to pee at night and you have diabetes, it shows your sugar is uncontrolled. If you go see your doctor, which is the next best thing to do, and for those who are diabetic, they need to check your A1C every 3 months to see what it is. If it's been less than 7, which is the ideal for a certain age, except the elderly, then you can do it every 6 months if you've had consistent low numbers. But every 3 months, you need to go check. So if you're waking up multiple times, you check, you find out that it's really high. Now, again, a take-home message. Everybody who's here need to get an annual well visit. But before you get an annual visit, get a primary doctor of your own, so that God forbid something happens, you can call that doctor on the spiel that, know their number, know their address and everything else. And then when you go for your check, make sure that they check screen you for diabetes. Everybody ought to know their diabetes status. Diabetes is a big issue and it's an epidemic. It is marching so strongly in the Black and brown community. We need to take careful. And some people who think, oh, it doesn't run in your family, but guess what? It can put you at risk where you're pre-diabetic. Now, before this, we did not know what pre-diabetes was. Everybody woke up one morning, boom, you have signs and symptoms, you're diabetic. But now when you screen yourself, they can tell you if you're pre-diabetic, no diabetic, or diabetic. Now, if you're in the pre-stage, meaning between 5.7 to about 6.5 without symptoms, then you can take actions about that. Exercise, watching your diet, everything else. Those things are really important so that you don't move over to becoming pre-diabetic. One thing we never knew before was that those who are pre-diabetic, those tiny, tiny changes that eventually end up in end organ damage really start when you're pre-diabetic stage. So, and that can occur 5 years before you're actually diagnosed with diabetes. So by the time you become diabetic, guess what? The damage has been going on for 5 years. So the earlier you know if you're pre-diabetic, the better for you so that you can take steps and doing it. And for me, the best thing to do is exercise. And I often joke, exercise a day keeps bad doctors away, but that's my own private joke. Thank you.
Thank you so much. Another question, or before I even ask that, I wanted to add that, drinking water close to your bedtime will keep you going to the bathroom. So try not to drink water too close to bedtime, like 1 or 2 hours before. So you would have gone to the bathroom and emptied your bladder. Otherwise, you get up to go to the bathroom. Another thing is if you're on water pill, you may want to consider taking your water pills in the mornings and not at night, because that will keep you going to the bathroom also. So just some housekeeping things, apart from, things that are disease entity caused, frequent urination at night. Dr. Aluya or Dr. Simon. Dr. Simon would, we've been here a while. It's a lot of questions and is en route. So Dr. Aluya, is Curalite supplement safer for diabetes than metformin?
What's that?
Curalite.
What's Curalite?
I have no idea what it is. Curalite supplement. We have talked about supplement and being careful about it. Is why I'm throwing it back to you, because I talked about it. So maybe you can say it in other words that can make it clearer.
Right. Again, I just talked about knowing your diabetic status. Everybody needs to know whether you're pre-diabetic.
Curalite and metformin.
Right. So
this person is already diabetic.
Right. So
metformin.
Metformin is still the #1 choice of medication for diabetes. Now, for those who are pre-diabetic, after we've tried exercise and everything else, and if it doesn't happen, I tend to put them on metformin so that it's actually been shown to prevent the progression of you ending up in diabetes. So, but the Curalite, I don't know what that is. But again, metformin is pretty safe. The issue of, it's gotten a bad rap for so long because some people in the
it's
industry
better than
want
Curalite because we
right.
don't do Curalite.
Some people in the industry want to destroy metformin, but then it's still the #1 drug of choice in the management of diabetes. Curalite, I don't know what it is.
Dr. Simon, do you know Curalite? I don't think.
No, I have never heard of that. I have no idea what that is. And I think I share your sentiment that because we don't know it, metformin is therefore better.
Amen to that. So yes, diuretics are not recommended for people with sickle cell anemia due to risk of dehydration. Yes, that's correct. That was said earlier. And the question is, losartan a good drug of choice for hypertension? Dr. Simon? Yes.
For Blacks, probably not the first line go-to medication for the reasons you've mentioned earlier. It does well for hypertension in Caucasian more than Blacks. However, if you have hypertension and you have proteinuria as well, or your pressure is not well controlled on a diuretic, the thiazide especially, then yes, addition of a drug like losartan can be very helpful.
Thank you. And Dr. Ezugu mentioned that valsartan seems also to work better. They're in the same class, but it seems like that seems to work better in Black people than the losartan. So you may want to discuss that with your doctor.
Yes, Dr. Aluya mentioned that earlier, that it was an observation he has noticed. And I started thinking about it. You know, as scientists, we always just think, right, to figure out why certain things will happen. And I know that losartan is the only ARB that has this peculiar effect, especially on the kidney. It's both filtered and it is also secreted by the kidney tubules. No other herbs has that property. So now I'm thinking and wondering, maybe because of the additional secretion is making losartan less effective as a blood pressure agent, because now less of it leaves the system much faster. In addition to it being filtered by the glomerulus, the tubule also secreted into the urine. But I'm going to look more into this to see if there are studies to show that this somehow has made it less effective as an antihypertensive compared to the other ARBs. Just a side note for the medical people that are on here. Thank you.
Thank you. Thank you. I appreciate that. And I'll get with Dr. Akinton. They will ask that question once you get back to us on that. Thank you. We appreciate it so we can prescribe right to our patients also. So there's a question here. How does taking consistent or constant multivitamins affect our kidneys long-term? If it does, thank you for all the information in this session. I think that has been answered.
So yeah, we sort of talked about that with the vitamin D as well, when we talked about those vitamins.
Correct. So any negative effect of stool softener on the kidneys? Is there any negative effect of stool softeners on the kidneys? Dr. Aluya, do you want to?
Not that
Sorry,
I
I mistakenly muted myself. I don't know how. So yeah, majority of stool softeners are well tolerated by the kidney. And the reason for this is because they act mostly locally in the GI tract.
and not a lot of them get absorbed into the system in a significant amount. So just your regular stool softener should not cause issues for your kidney. Now, this is different from when we use enemas, for instance, because in very severe cases of constipation, you know, we've had people have to go through use of enema. Down the fleet enema, that's mostly phosphorus based. Some people used to be used back in the days also for colonoscopy preparations. A massive amount of it is injected through the anal region. A lot of those gets absorbed, and they get absorbed in significant amount, and they can precipitate calcium phosphate stones in the kidney. We've had cases of renal failure from the use of fleet enemas. So I think it was withdrawn from the market somehow, but it's still being used in some places sparingly. So I tell people to watch out, especially if you have CKD and you need an enema. Do not use the what we call fleet, FLEET, or the phosphate-based enema. It's not really a stool softener per se. So, but your regular stool softener that you take by mouth should not have any issues with the kidney. Thank you.
Thank you. So you don't use that in chronic kidney disease. But if you don't have chronic kidney disease, it should be okay, correct?
With the fleet enema?
The fleet enema. Is it okay?
No,
or
we've
just
seen it
avoid
cause
it?
kidney damage in people with normal kidney function.
Oh.
Yes.
So
yes.
avoid fleet enema.
Avoid fleet enema if you can. And if you especially have kidney disease, then you should even run away even more.
Fantastic. Thank you so much. So how damaging to the kidney or the liver is the daily use of 81 milligram of aspirin? That's an excellent question by Mr. Lawal.
Yeah, I will speak from the kidney perspective. 81 milligrams of aspirin poses no significant risk to the kidney in terms of kidney damage. Now, theoretically, platelet dysfunction or bleeding risk may be somewhat increased if you have significant kidney issues and you're on aspirin. That's because kidney disease by itself can render your platelets dysfunctional. And so we know that aspirin is a blood thinner. So if you're on it and you have significant kidney issues, your blood may thin relatively more than if you had no kidney issues on baby aspirin. So just something to keep in mind. But otherwise, the normal kidney function on baby aspirin, we don't have any data of significant risk to the kidney.
Fantastic. And, if I may, just say something else about that. Somebody asked a question about the NSAIDs, ibuprofen and all of that, and Tylenol. Tylenol is in another group. It does not get cleaned out, if I may use that word, through the kidneys. It gets cleaned out through the liver. And believe it or not, don't take too much Tylenol because you can actually destroy your liver. It can actually kill somebody if one takes too much Tylenol. And like Dr. Simon said, these things are sold over the counter. We have to be careful. Somebody said they were made to understand that older people don't get thirsty. Is that correct, Dr. Simon?
Partly correct. And we try to make it as simple as possible. As we get older, our organs don't function.
Okay, so we can't hear you. I don't know if you muted again. Yeah, you muted. I'm unmuting you. Dr. Simon, you're muted. Great. You've unmuted.
Sorry, can you hear me now?
Yes.
Sorry, I had a call coming. Yeah, so the brain in older people, probably you can evaluate that it's not as sharp our memories are not as sharp as we get older. Yes, and the ability to perceive thirst starts from the brain, in the hypothalamus, for instance. Older people, if they've had a stroke involving this area, even if they are not old, if you have a stroke even at a younger age, but if it involves this area, your perception of thirst may become muted or significantly decreased. And then as you get older also, it may just reduce. It is true. And this is where maybe the water intake, we try to tell people, especially in the nursing home, who have a stroke or can't swallow and they have a PEG, and now we prescribe a certain amount of water that they need to drink. Now, in those circumstances, it is within our control. We know the food we're giving them. We can easily estimate how much water we think they need. And we monitor their blood work also for their sodium, because your sodium level will go up and down based on how much water you have. So if you need more water, we say, okay, you need to add more to what we already prescribed. So, but by and large, it is true in older people, thirst perception is decreased, but not significant to the point to perturb your sodium homeostasis. Sorry for those words, sodium balance. Let me put it that way. Unless if you had a stroke and now you're not really just able to even sense that at all. And then that way the doctors take over and tell the family how much water they should give this person per day. Thank you.
Thank you. Is the vitamin D from fruits when eaten frequently harmful? And it's not harmful. Eating fruit is okay. Too much of everything is bad, as we have been told, earlier on. I think everything in moderation is what we should do. Also, there is the question, what of in the case where you just must drink water? You get thirsty all the time. As Dr. Aluya has said over and over tonight, it will be important to see your doctor. And as Dr. Simon had said, important to do lab work to make sure you don't have diabetes, because that's one of the things that will cause you to be thirsty all the time. And there may be other reasons why you're thirsty. It's important to see the doctor to decipher what that could be that is causing that thirst. So Dr. Aluya and Dr. Simon, the Sister Denike, who asked the question about the supplement versus metformin, said it is Curalin. Curalin supplement, I still don't know what that is, compared to metformin. I don't know what it is, but I want to say that on our platform tonight, we have our very own, this is US Rep Oye Owolewa on the platform, Dr. Oye Owolewa. And he said he has thoroughly enjoyed this conversation and thanks for all. And, thank you. I don't know if he's still on to say something, but Sister Lami Dogonyaro, you can unmute. Sister Dongoyaro, you can unmute to ask your question. Okay.
Can you hear me now?
Yes.
Okay. I tried to type it in, but for some reason I'm locked out.
Oh.
Yeah. Anyhow, I wanted to ask, how often should one take a regimen of baby aspirin? And it's a two-part question. And what medication? I know Dr. Aluya and I think Dr. Simon said something about the most popular medication for diabetes among Black people. I didn't quite get the name. Can you please type the name of that medication? Is it Medford or Med?
It's metformin. Metformin. MET.
Could you type it for me, please?
Absolutely. Metformin. And what was your first question again?
Okay, like baby aspirin. I think a long time ago, I was made to believe that if you take a baby aspirin, it's good for your heart.
Dr. Simon just answered that question, that 81 milligram of baby aspirin a day will not in any way hurt your kidneys. It will not.
So I was just thinking maybe to take it every other day.
No, it did not say that. It
Okay.
said taking it once a day will not. And Dr. Simon, can you unmute and answer that question again, please? Thank you.
Yes. So still on baby aspirin. Can you hear me?
Yes.
Yeah. On baby aspirin, correct?
Yes. On
Yes,
baby aspirin, she wants to know if, it is safe to take, and also should she take it every day or every other day? She wants to be sure of what to do.
So follow your doctor's prescription. If you have a normal kidney function, baby aspirin is safe to be taken every day. I don't know. I would love to hear Aluya's perspective on baby aspirin and cardiovascular health for primary prevention. Really, we know that for secondary prevention, it's beneficial. But a few years ago, there was a conflicting report about its use for primary prevention, meaning people who have never had a stroke, who have not had any heart attack. Is the benefit of baby aspirin daily worth it, given the risk of bleeding and other things? Now, as far as the kidney goes, it's okay, but I just wanted them to talk about, is it even worth taking if you've never had a stroke, heart attack, or you don't need any secondary prevention? Dr. O, maybe you might know, you might have any comment on this, and Dr. Alia, certainly. Thank you.
Thank you.
Yeah,
Actually, there's talk about that now. Dr. Aluya, I'm going to defer to you, but the standards we had before that at the age of 40, you should start taking baby aspirin has changed. So I'm deferring to you to complete that.
Yeah, so just like Dr. Segun Simon said, yes, there's a study that came out saying for primary prevention, it doesn't do much, meaning if you've never had a stroke or any of those things. However, if you had one incident of stroke or any other cardiovascular risk, valvular issues in the legs or any of that, it really does help. However, with every study that comes out, we need to pay attention to a lot of things. How many of us, of Black people, are in that study? What was the breakdown analysis of that study? And how does it reflect to us as a people? So, but for me, in all sincerity, once you're of a certain age and you have high cholesterol and diabetes is uncontrolled, high blood pressure, I put you on whether you had stroke or not. Because the first thing in our community, like I said earlier on, we do have a hyper-inflammatory state. We're constantly in a state of inflammation, and that can put us at risk for multiple things. So I tend to put people on that if you have diabetes, high blood pressure, or high cholesterol, so that we don't wait for you to get a stroke first or for you to get a heart attack before that for Black people.
Thank you. So, Dr. Aluya, we have been on this forum for a while. Can you give us your concluding 1 minute encouragement? And then Dr. Simon will round it up for us with what he wants to leave for us to conclude this. And I want to remind us all that we have not established patient-physician relationship on this platform. All we have come together to do is to give you current, cogent, and authentic medical information to help prevent, kidney problems. So, Dr. Aluya.
Yes, take care of your health. Your body is the only place you have left to live in. Have a primary doctor. Get an annual well checkup. And before you go, I always say this, going to see your doctor is like going to church. You dress well, you get prepared. Write down everything that you need to discuss with your doctor. Write them out and outline. Because often enough, unless you're a new patient, you have 30 minutes to spend with your doctor. But if you have a follow-up, it's only 15 minutes that the insurance company or even the government has allowed. So 15 minutes is not enough. So if you come and you're not well prepared, you're blabbing away, the doctor will not have time. So go prepared, write down whatever, write in the area of priority so that you address those things first. And those are the things that are most pressing. Now, if you don't have that, you set up an appointment for follow-up to discuss those reports. Now, anytime you do your blood work, please set up a follow-up appointment with your doctor to discuss your results. Because a lot of people do blood work and they don't show up for 1 year, 2 years. And God forbid, if your doctor failed to see that result, it therefore means your kidney problem, your liver problem is out there and nobody's seeing it. So set up an appointment within 2 weeks to follow up to review your results every time you have one done. Thank you.
Thank you so much. Oh my gosh, that is so important. Every single word you said is so important. Thank you. God bless you, Dr. Aluya. Dr. Simon, kindly give us your parting words for tonight.
Yes, so we have spoken for, I would say, about 3 hours now.
Yeah,
Almost.
I would say so. Of course.
Yes, close to it. And this will be my summary for the night. First, in addition to what Dr. Aluya has said, do everything in moderation, number one. Two, we can't emphasize this enough. Please get checked. And we are at an information age. If there's something you don't know, you can research it. Now, if you're not sure, you need a doctor. Ask your doctor. I'm sorry I cannot come on the video anymore because I'm sort of in transit and I don't have a good lighting where I am. So, but I hope you can hear me.
Yes,
do everything in moderation. Get yourself checked. Talk to your doctors. And if you have a chronic condition, by all means, manage it well and work in a collaborative effort with your doctor. Like Dr. Aluya said, preferable, if you can find a doctor that looks like you, eats what you eat, is more likely to be able to identify your problem better and give you, and the quality of your care will be better. And number three, this is the biggest one. On the kidney, you should know your kidney number. If anyone asks you what's your kidney number, that's what I call it. It just means the percentage of what your kidney function is. 30%, 50, 70, you should know that. And that's my message for the night. Thank you so much for the opportunity, Dr. O. I appreciate it. And God bless all the work that you're doing.
Amen. Thank you so much. I appreciate you. God bless you. Thank you. And Dr. Aluya, thank you. My darling brother and my president, I appreciate your leadership. Thank you. God bless you. God bless you all and have a blessed and fabulous night. Till we meet again next week, please stay safe.
Good night, everybody.
Good night. Thank you. Thank you. Thank you.
Good night,
Thank you,
Dr. Aluya.
Thank you.
Good night.
Thank you. We
Good
love you
night,
all. Thank you.
everyone.
Hallelujah,
Good night.